Thank you very much for the kind introduction. And first of all, I would like, of course, thank the organizers for inviting me to this terrific and interesting scientific meeting, the Emirates Neurology meeting on multiple sclerosis. It's really a pleasure for me to present my own insights on secondary progressive multiple sclerosis and our personal experience, in particularly with the novel immunomodulator siponimod in our Essen SPMS cohort. So first of all, some basics on SPMS in general, and I'm very well convinced that most of you are pretty much familiar with this. So of course, we all know that in the vast majority of the patients, the relapsing remitting disease form, the RRMS, transites into a secondary progressive disease course within a time period of approximately 6 to 10 years if the patients remain untreated. Of course, SPMS is a somewhat more severe disease condition and disease course compared to the classical relapsing remitting MS form. Patients with SPMS usually suffer from a worse physical function. They do have greater cognitive impairment, and they are also more often unemployed compared to RRMS patients. If one translates this into MS pathology, then one can state that the inflammation in the secondary progressive MS subform in the CNS is somewhat more compartmentalized, meaning that there is more diffuse and some sort of smoldering inflammation in the CNS behind the blood-brain barrier. We do find a lot of cortical demyelination, and there's some sort of slow expansion of white matter damage, but it's not only limited this damage to the white matter, but it rather also includes the gray matter, including neuronal and axonal damage, thereby reflecting secondary neurodegeneration. So as soon as there's some sort of cumulative axon degeneration surpassed, then the functional capacity goes down and permanent neurological disabilities take place and are fixed. So how do we diagnose SPMS nowadays? It's not an easy task, and there's no easy answer on this, and why this is the case is represented on my next slide. A very simple cause is that still there are no clear diagnosis criteria of secondary progressive multiple sclerosis, meaning to determine the conversion from relapsing remitting to secondary progressive MS. Usually, we do diagnose SPMS on a retrospective base, based on the history of gradual worsening. So usually, as depicted here on the left side, it all starts, of course, with the classical relapsing remitting disease course. Here, the patients do show clearly and well-defined MS relapses, and usually, at least at the very beginning of the disease history, there's full recovery from these relapses. But then in between, after a time period of approximately 5 to 10 to 15 years, something happens. There is a slowly progressive transition from this relapsing to the progressive form. So the relapse frequency goes down. The patients no longer fully recover from relapses, and this underlying progression becomes more and more prominent. And finally, in the end, somebody, usually the treating neurologist, says now this patient on a retrospective base suffers from secondary progressive MS. No more relapses or only very few relapses, an increase in disease progression, and I already mentioned the neuropathological correlates of this clinical cause, namely neurodegeneration and diffuse smoldering CNS inflammation. Of course, the question now is, can we identify the transition from RRMS to SPMS better in the future? So there's a lot of research ongoing in terms of biomarkers, for instance, imaging biomarkers, but also blood and CSF biomarkers. But one has to state that this is still in the preclinical setting, in the research setting, and they are not yet ready to really enter the clinical market. Another practically highly important point is that the definite diagnosis of SPMS is often very much delayed in clinical practice. And this is depicted here, data from a study in 20 SPMS patients, a long-term cohort of patients with MS followed for more than 8 years. And the top-line results from this study is that approximately 70% of these patients had and experienced a period of diagnostic uncertainty in terms of secondary progressive MS. And this period of diagnostic uncertainty, this is depicted here, the last visit with definite RRMS to the first visit with definitive SPMS, this uncertainty, this period, this window of diagnostic uncertainty can last between 3 or even 4 years or longer. And this is really remarkable. And of course, during this window of uncertainty, we do lose diagnostic opportunity, not only diagnostic, but in particular therapeutic opportunities. So usually during this time span, our patients who have already entered the progressive phase are not properly treated. And this is a very practical problem we as a neurological community should address. Why is it that both patients, but in particular also the physicians and the relatives, are so hesitant and reluctant in diagnosing SPMS? Well, there are probably lots of factors related to this, but data coming from different studies, including the study depicted here, tell us that many of our colleagues, and probably also ourselves, they are quite hesitant due to the high psychological burden associated with the diagnosis of secondary progressive MS. When we talk to our colleagues, they tell us, well, it's very difficult to communicate this novel disease course, this more severe disease course, which has a worse prognosis to our patient and his or her relatives. There is denial, panic, and grief with the patients. Also, it's hard to find the optimal timing of informing the patients about this new disease course. Many patients tell us that they feel completely unprepared, but it's not only the patients, it's also us, the physicians. We are not trained counselors, is here some citation coming from a neurologist from this study. So there is only limited access to, for instance, psychological support, both for patients, for caregivers, and the families. Many of them are also rather reluctant to seek any support. And we all know that there's a lot of work to do around our hospitals and private practices, in particular during the times of this corona crisis. So a lot of reasons, also psychological reasons, why we and the patients are reluctant in finding the right diagnosis. There's also some very practical reason, namely that until recently, there were simply no appropriate treatments against secondary progressive multiple sclerosis available. Until recently, at least in the European Union, only interferon beta-1b was approved for SPMS with disease activity, relapses, or MRI activity. We had some alternative with mitoxandione, which is indicated for very highly active relapsing MS, and this also includes a relapsing progressive MS. But we all know that mitoxandione comes with several specific problems, such as long-term cardiotoxicity, or an increased risk of inducing hematological neoplasias, in particular leukemias. This situation has changed, and I will come back to this in a minute. Since the approval of siponimod in the European Union, siponimod is indicated for the treatment of adult patients with SPMS with active disease, evidenced by relapses or imaging features of inflammatory activity. This is different in other parts of the world, including the Emirates and Saudi Arabia, where the label of siponimod is much broader and can be applied and prescribed also to MS patients at a much earlier stage of the disease. So, This said, and against the background of the various problems coming with the treatment and the diagnosis of SPMS, one can ask the question, should SPMS maybe diagnosed earlier? And I think the answer is yes. And why is it the case? Well, first of all, we know from studies in clinically isolated syndrome that cognitive deficits, which are key in MS patients and put a high medical burden on our MS patients, that these cognitive deficits occur very, very early, at the early stages of the disease course. So cognition is key, and cognitive deficits occur very early compared to healthy controls, in particular cognitive deficits related to memory, speed of information processing, attention, and executive function. So we do have early cognitive deficits, but we also do have early progression. And this progression not only occurs at EDSS scores higher than 5 or 6, no, it already occurs at EDSS scores below or equal to, and this is depicted here. I regard this study as very astonishing, surprising, and interesting, because this study clearly showed us that onset of progression at very low EDSS levels is not a rare event. Have a look at this. So in this study here, including patients with SPMS diagnosis, in this study, 70% of the patients received their SPMS diagnosis at an EDSS score of 6 or higher. So at a stage of the disease when a lot of disability had already occurred. But if one looks back retrospectively, 85% of these patients had experienced an onset of progression already at EDSS levels below 2. And this progression was clearly separate from original attacks and relapses. And even the patients have recognized this progression by themselves. 77% of the patients had recognized their disease progression already at an EDSS stage below 3. And this tells us that progression is not something that happens only at the late stages of the disease, but occurs at the very earliest stages, and, for instance, can induce cognitive deficits, fatigue, and other symptoms also at the very beginning of the disease. So can we do better in diagnosing multiple sclerosis? We think yes. We can use the EDSS score, we know this, to identify patients with secondary progressive MS, but in everyday clinical practice, the EDSS comes with a lot of limitations. We know, yes, at EDSS score higher than 3 or 4, it might be useful in predicting or defining SPMS, although we are well aware that progression can already occur at EDSS scores of 2 or even lower. I showed this in my previous slide. But the EDSS comes with a lot of limitations. For instance, it mainly focuses on the walking ability and does not adequately address and assess the upper lip function, and not at all the cognition. Collecting the EDSS in everyday clinical practice can be very time-consuming and might be restricted in particular to clinical visits, which may occur only infrequently. And also, EDSS is very prone to intra-rater variability. So can we do better? I think yes, and this is why I want to introduce to you the so-called MS Pro Discuss tool, which is a novel and integrative SPMS evaluation tool combining patient, physician, and empirical assessments. And this tool has been developed in collaboration between Novartis and very experienced MSologists and neurologists. And this is how it works. So first of all, there was a development of a draft physician-completed questionnaire. And this questionnaire assesses disease activity during the last 6 months, the symptoms of MS, and very important, not only the symptoms, but also the concrete impacts related to these symptoms also during the past 6 months. Then there was some statistics, regression analysis, and a ranking and weighting of the parameters collected here in order to assess how strongly each key variable concept was associated with the progression from RRMS to SPMS. For instance, motor symptoms are very important, new MRI activity, and also other parameters like the time since the first diagnosis. Then the questionnaire and the scoring algorithm were combined. There was some digital version now of this prototype of tool, the MS Pro Discuss tool, which is available online. And finally, of course, very important, some psychometric validation occurred to check for sensitivity and specificity of scoring algorithm between RRMS and SPMS, the inter-rater variability, and the usability of the digital tool. And this is how it looks like in the online version. So I would like to quickly go through to it. So first of all, of course, you have to collect some baseline characteristics like age and EDSS, and then it comes already to disease activity, MRI-based and clinically based, in particular relapse. Then further on, the symptoms, the system is asking you the symptoms of the patients, a little bit like the EDSS, visual, motor, ambulatory, and so forth. So one has to enter the symptoms. And then, this is what I was already mentioning, the concrete impact of the symptoms on mobility, self-care, daily activities, and so forth. And in the end, some sort of traffic light system result comes out telling you in green, in yellow, or in red, the likelihood of this very patient to have entered the secondary progressive disease stage. And these individual patient data are then, so to say, compared to the data in the MS Pro Discuss database. And in the end, the system tells you how likely is it that the patient sitting in front of you had entered the SPMS phase, with the red light indicating a very high likelihood, for instance, of having entered this very phase. So it's a very innovative online-based tool. It's a validated tool. We are currently also using this tool and validating this tool in our own MS outpatient center in Essen, Germany. And I'm really keen to see the results in the upcoming 6 or 12 months, and how the practical value of this new diagnosis tool is. And during the last part of my talk, I would like to present you our first insights into our cohort of SPMS patients treated with siponimod here at the University Hospital in Essen, in Germany. So as of December 2020, we have treated 24 patients with siponimod. We screened 33 patients. Currently, there are 24 patients on drug, and another 9 patients are ready to go and are scheduled for siponimod treatment. From these 9 patients, we had 2 screening failures, and those screening failures were due to cardiac disease, thereby excluding the application of siponimod, as you will probably appreciate, and also some sort of non-compliance due to a comorbid psychiatric disease. So 24 patients on drug, and I'm sure that you are all well aware that before putting patients on siponimod, one has to check the CYP2C9 genotype in order to assess whether a patient is a slow, an intermediate, or a fast metabolizer of the drug. And depending on the result, the maintenance dose needs to be adapted. But I can tell you that in our cohort, none of our patients had to be excluded because of this STAR3 genotype. In only a handful of patients, we had to reduce the dose to the 1 milligram per day maintenance dose, and the vast majority of our patients could be put on the regular 2 mg per day dosage. Some baseline characteristics in our cohort: so 9 patients are female patients, the rest of our patients is male patient. The mean age is around 58 years, so pretty much reflecting secondary progressive MS cohort in Germany, or at the German University Center, a more advanced disease stage, of course. But as you can see here, the spectrum of the age distribution is rather broad, ranging from 43 to up to 79 years even. Disease duration, meaning the time from diagnosis until the treatment onset with siponimod, on average is approximately 20 years. Again, the bandwidth is rather broad, ranging from 1 year up to 37 years. And this truly, of course, reflects real-world data compared to the situation in controlled clinical trials. And what we do, of course, on the base as a baseline routine is to assess the EDSS, and the mean or median EDSS is depicted here. So in our cohort, the mean EDSS is 5.9, also already a rather severely affected group of patients, with a minimum of 2.5 and a maximum depicted here in this plot of up to 8.0 on the EDSS scale. Prior DMD treatment is also, of course, an important issue when it comes to real-world cohorts, because previous treatment, of course, might have an impact, maybe a negative impact, but also a positive impact on the efficacy of a certain drug, but also on its safety profile, of course. So the mean number of previous or prior DMDs in our cohort before putting the patients on siponimod currently is 2.5, or a median of 3. And there's once again a very large distribution of previous DMDs, ranging from 1 prior treatment only up to 2, 4, 6 previous treatments before those patients were put on siponimod. So a great variability also here. And when one has a closer look at the different compounds, you can find many of those expected for such a cohort. So we switched patients in our group from fingolimod to siponimod, but also from the injectables, and even from high efficacy B-cell depleting treatments like ocrelizumab, rituximab, and others, even mitoxantrone. So it's a great basket and high variability when it comes to the concrete and individual compounds the patients were previously on before being switched to siponimod. Again, this very well reflects the real-world setting. What kind of parameters do we assess in our siponimod SN cohort? I already mentioned the EDSS, but we do a lot more assessments, including the time for 25-foot walking test and the 100-meter walking test. We conduct the 9-hole PEC test, or our patients have to conduct it, and we also put emphasis on cognition. I mentioned the importance of cognition at the very beginning of my presentation, in the form of the PASAD and the single-digit mortality test. So in the next slide, I would briefly show you our first preliminary efficacy results of siponimod in our cohort. First of all, the EDSS over time compared against baseline. By nature, I can only present you data until month 6, because siponimod in Germany has only recently been approved and entered the market. But simply by eyeballing, I think you will appreciate that until month 6 in our patient cohort, there was no change in the EDSS score over time, which is reassuring. Also, for the time for the 25-foot walking test, the data points and the average results expressed here in seconds remained stable until month 6. There are some individuals who showed some sort of deterioration over time for this test, but on average, this difference was not statistically significant. The same holds true for the time required for the 100-meter walking test, again, compared to baseline, and then month 3 and month 6, no significant differences. 9-hole PEC test to assess upper motor function, also stable results over time when one compares baseline and the month 6 time point. And finally, the cognition assessments, the PASAD-3S. Also for this parameter, we found stable results over time, and the same also is true for the single-digit mortality test. So overall, although we are fully aware that those are still preliminary results, the drug was very well tolerated in our patient group. The previous or the preliminary assessment is reassuring and shows a stabilization of different functional parameters, including EDSS, but also parameters addressing cognition and other function. And with this, I would like to end. I thank you very much, of course, for your attention. Thank you very much again for inviting me to this interesting conference. And now I'm happy to take your questions. Thank you very much.